this is actually one of my favorite conferences because the audience are fellows, and it means that you still hopefully are impressionable. You haven't learned it all yet. You go to some of these conferences and it really is kind of like a practice in people like patting each other on their back because, so, you know, but I hope you guys appreciate what you've gotten so far. You know, we had a discussion on stem cell yesterday. We had just tons of talks on you know, neuromodulation with all types of waveforms. You got Doug Beal, who's, if it wasn't for the Bible, would have published more than God himself. So you have this huge body of people who are really good at what they do. And I hope you guys can appreciate that. I'm going to talk today a little bit about intrathecal targeted drug delivery, and then you're going to see me again at lunch, in which case I'll get a little bit deeper. So this talk will be, even though it's touching on intrathecal targeted drug delivery, it'll also be, unfortunately, you're stuck with my philosophy for this period of time during the talk as well. So those are my disclosures. I'm an interventional radiologist, so this is my typical day. You know, for whatever reason, I've as I started doing chronic limb ischemia, I actually do a retrograde approach where I'm sticking either between the metatarsal proper arteries or dorsalis pedis or posterior tibial and treating people retrograde. And so it's not a lot of people doing that. And so after people found that out, they start sending me stuff like this, you know, and then stuff like that, and stuff like that, stuff like that. This is a guy I did Friday. The significance of this and why I say is we do about 70,000 amputations a year in this country. These people present and like, this lady was sitting out in the waiting room and she's just bawling. You know, when you look out in the waiting room, you see something like that, you're like, what's up? Oh my gosh, what's wrong with this patient? Then you get in the room and you see stuff like this and you understand why that person is bawling. Like I said, we do 70,000 amputations a year. In the first 30 days, 10% of those people are dead. Chronic limb ischemia, within the first year, about 25-30% mortality. Within a year, about 25% of those people have at least had amputation, and the rest are alive with their foot. So looking at that, what that really means in terms of cancer and the cancers that kill people, clearly we know that lung cancer is number one. The second killer in the United States on a year-to-year basis is actually chronic limb ischemia, killing about 52,000 people a year. So understand that my perspective is slightly going to be different. So I want to talk about this patient because I'm in private practice. I've been in hospital practice for a long period of time, but based on my vascular experience and my pain experience, these are the type of patients that I can now take care of in my clinic. This guy is 69 years old, had been really a productive guy, trauma to his spine. He's now wheelchair bound, but still really, really active, really, really bright, really involved in his church. He comes in with these wounds, and so this is by definition chronic limb ischemia. You got tissue loss and vascular compromise. So this guy gets treated. Then I end up evaluating him. I end up treating his other leg. When I augment arterial flow to his leg, he now presents back with lower extremity swelling, which means he has some venous outflow issues. So now I use intravascular ultrasound, I evaluate. He has venous stenosis, that's treated. But the whole time I'm treating this guy, he's on the table and he's wheelchair bound. He has such violent contractions that he would literally contract off of the table. And I have to, and there's nothing you can do for those type of contractions. So I would just have to let him relax so he could reposition himself on the table, and I start the angiogram again. But frequently during that time, he's spasming so significantly that I have to, I'll lose an angiographic run because once you start moving, I can't go with that run anymore. So through those 4 previous interventions, I was always telling this guy, hey, you know what, we should really talk to you about maybe a pain pump. He knows nothing about it. So I started talking to him about possibly a trial of baclofen. Long story short, we do a trial of baclofen. This guy, like I said, he's really active in his church. He's like, I think this is why why God really sent me here, is because this is a miracle. He said, you have no idea. His contractions were so violent that he couldn't sleep through the night. He's basically waking up from these violent contractions. Like I said, this guy got a trial, he got a pump. Now he's living on 25 micrograms of baclofen a day, and he's absolutely perfect. He calls it a miracle. He comes in smiling every day. He's driving. He's a really independent guy, but with the contractions, he got to the point where he couldn't drive himself because he didn't know when these spasms were going to hit. Now he's driving again in his van, and this person, his life has been changed literally by his intrathecal drug delivery. So a couple of things I want to just touch on briefly. This is literally the 60,000-foot view, because we're going to go through some of these things really quickly. In terms of history, there's just a description of intrathecal anesthetics in 1885, 1901, intraspinal morphine. You see in 1982, Medtronic reports the placement of its first intrathecal pump. 91, they released to the market. 2006, I placed my first pain pump, and I actually started off in the cancer pain world. I'm doing more pumps now for, I have a young lady scheduled for chronic interstitial cystitis who's basically not responded to anything. I have people with chronic pancreatitis, post-laminectomy syndrome. So even though I'm placing it now more regularly for other issues, my genesis really was in pancreatic cancer. And I always say from that point, I never looked back because you can, in the cancer pain world, specifically when people enter that period of cachexia and they're just wasting, the results can be almost miraculous. And I tell a story of a family. I went to New Mexico Cancer Center after I got out of Air Force around 2010. And I had been there for a while, just talking about pain pumps. I placed a pain pump, and this guy came back with his wife and his two daughters, and they were angry, sitting in the waiting room for me. And his issue was, why did they let me suffer so much when this works so well? Within a month and a half, he was up about 10 pounds, and so has a significant ability to really impact people's lives in cancer patients. Some of my most rewarding cases. 2012, Medicis is given FDA approval for the newest intrathecal system in our market. So what's the real issue? The real issue is pain control. In the job that you're working in, you're going to see patients who come in with really clear, identifiable issues. But I was talking to my colleague this morning. What happens when that patient comes in with absolutely normal imaging for everything, and their only issue is abdominal pain? What can we do for these people? Well, what's typically been done, these people have been given hydrocodone. When you look globally and see that we use 99% of any pain medication in the world, what is it specific about Americans? Do we experience pain somehow different than our global counterparts? Obviously not, but it is an issue of how medication has been prescribed and how it's been marketed. 3 out of 4 people, though, that misuse pain medication will tell you that they've actually not gotten it off some street source. They've either stolen it from some family member or they've basically removed that from someone who had a legal prescription. Or, obviously some clear diversion happens. Just some old numbers. 2014, we were talking about 19,000 deaths from opioids. By 2017, I think the last thing I saw was over 72,000 deaths. And it's to the point now where, reversal agents are being given along with prescriptions, or on certain college campuses, reversal agents are being made available for students based on the fact that a lot of these medications are being abused. So in my pain practice, the typical patient I'm seeing is a patient that has sometimes been instrumented, most commonly my patient who's doing best have been people who fail laminectomy. But I see a lot of people who've had multiple level fractures who go on to have chronic pain. But then, like in the lower portion, I don't know if you see that this person had a renal malignancy and got treated somewhere else and basically developed intractable pain following local regional ablation for renal cell carcinoma. So really looking at the data, I was talking in the lab a little bit earlier. If you talk to most physicians, and when I say most physicians specifically dealing with cancer pain, you're talking to oncologists. When I talk to my oncologist colleagues, they swear that they have excellent pain control for every cancer patient in their clinic. But if I end up talking to any of the nursing or the support staff, they can tell me, oh yeah, Miss Johnson or Mr. So-and-so, their pain is terrible. We're throwing everything we can at them. And if you look at these numbers in terms of cancer prevalence of 1.5 million patients, and then looking at the group that we like to treat, those people with greater than 3-year life expectancy, 3-month life expectancy, you got 161,000 people. And then of the people that have severe pain, you're seeing a third of those, and then people who will not respond to standard of care, which is going to be long, short-acting opioids. You see that we have almost 200,000 patients, and a good portion of those have life expectancy where we would want to treat them. The majority of these people we're seeing, a lot of the people, pancreatic cancer, or people with diffuse bony mets. I arrived at the cancer center at the beginning of the year, and there wasn't a lot of experience with the use of intrathecal targeted drug delivery. Within that first case I talked to you about, where the guy came in with his wife and 2 daughters, it got to a point where if a person presented with pancreatic cancer, most of my 9 oncologists that I work with were referring these people for placement of pump because they just did so much better. I talked to Lisa Stearns and some of the people that refer to her, and one of the things she points out is that by maintaining people at a certain level of productivity, a certain performance status, then you're more likely to be able to survive your chemotherapy. So some benefits, or where I've seen good luck, is when oncologists recognize that these patients are able to stay on protocol and receive the chemotherapy, which, based on most of what we know, is their best chance to be able to get their full treatment. So a couple of randomized controlled trials out for cancer pain demonstrate significant pain reduction in contrast to typical therapy, reduced toxicity, and that can be anything from just adverse effects to what a lot of people will talk about, specifically as their doses become higher, is mental clouding. So imagine that you are a person that has X amount of survival that's expected, and the majority of your days to get adequate pain control, you're obtunded, So yeah, and that's what I hear a lot. If I'm on the if I'm taking my medication to the point where I'm awake, then the pain is usually too significant. So basically what I'm doing is kind of sleeping my life away. And I can tell you story after story of people who are at that kind of later stage of their life. They've kind of embraced their mortality related to their illness, and they want to do things. Like I had one florist. He wanted to go to work and work with his flowers. That was his definition for his quality of life. And one of the things that I do in my practice is I really do focus in on that. When it came time for me to go and start my own office, I was looking for that kind of vision statement, and that's something I got from the military. Almost every unit, based on what we did, we had some type of vision statement, and the vision statement that overrides my office is pursuing quality of life. And whether that's in doing things like kyphoplasty, whether in, I just treated a guy, he had one amputation, still he had prosthesis, but he presented 2 years later at the same entry process that cost him his other leg. And that started with toe ulcers that went on to osteomyelitis, they said they couldn't do anything for him. They amputated him. Well, he presented to me kind of the same situation: toe ulcers, osteomyelitis, and we have hyperbarics and all these other things we do. If you can't get blood to a wound, it's not going to heal. If you can't get blood to an infection, I can give you antibiotics all day. It's just a waste of time. And so just doing those things to help people pursue that quality in their life is kind of the overriding theme of our practice. The other thing that I thought was significant, even though it didn't reach significance, is look at the survival benefit at 180 days. When you look at stage 4 cancer, 180 days exceeds their typical survival. So when you look at, and you can compare 54% versus 37%, even though it didn't reach significance for that patient with cancer who has mental clarity and better pain control, that's significant. The other thing that happened in 2015, if you are in really a strict cancer practice, the NCCN Guidelines guide everything from treatment, for the treatment perspective for the cancer patient. And in 2015, it got entered that these people, that the intrathecal route of opioid administration should be considered as specifically for people with intractable pain. It was called a valuable tool. The other thing is that you see is with adequate pain control, you get better resource utilization. Now, I had a lady with breast cancer, lymphangitic spread to her neck. We gave her a pain pump. She survived another 3 months after that pain pump placement. But what was significant for her is the previous 2 to 3 months before presenting, she had an average of 2 ER visits per month, and sometimes more. So if you can affect resource utilization, then you can significantly, it makes the use of the pump significantly more cost effective. And then speaking of resource utilization, okay, this is kind of that philosophy portion. Just a little bit of my background. I was in the Air Force for 28 years. 14 of those years I was enlisted. The final part was my medical training. I went out and did like most interventional radiologists do. I went to a hospital. I gave my benefits, services, intellectual property to that hospital. Almost every hospital I had gone to didn't have any significant cancer program. They had no pain program in terms of early bone metastasis treatment. I was doing microwave, RF. I was doing all of these things. And I kind of shared this story with a couple of people. I got to the point where I hated going to that hospital. I continued to give more and more of myself. I was finishing cases at 7, 8 o'clock at nighttime, doing new patient consults at 8, 9 o'clock at night. And I got to a point where I was just, one day I was sitting in we had an underground parking lot, and I was sitting there just really trying to pray myself up to the point where I could go in and continue to do this thing. So one of the best things that happened to me, kind of even following partially behind my mentor, was the fact that I'm in private practice now. And the way it happened, it was really miraculous. I was having a drink with a guy, a friend of mine in a restaurant. He goes, "You know what, I gotta introduce you to this guy." As soon as he said that, the guy he wanted to introduce me to walked into the restaurant. Then that guy, we started talking, we hit it off, and he's like, "You know, I got these 2 rooms in the back of my office. I use them for storage. I can get them cleaned out and I can give them to you. And oh yeah, by the way, I have 2 old tables and I got this old ultrasound machine." Swing forward 3 years, I just moved into 6,000 square feet. We have 3 ultrasounds now. I got laser, pretty much everything. We're teaching site. We just named the Center for Vascular Excellence. But the biggest thing is I'm happy. Hadn't known happiness like in what I did and what I loved in so long. So inevitably, life's gonna give you a crap sandwich. You guys are young, but life is gonna hand you a big fat crap sandwich and it's gonna say, "Take a big bite." And while you're chewing, I want you to remember, and you gotta think about why you're doing what you're doing. And most of the time you start talking to people, and I've even gone out, even before I read this book, I would go out to do marketing for the office, and I go out and I got all these things of what I can do. I do RF, and I do chemoembolization, I do pain pumps. What you do never motivates people. Why you do what you do is what typically motivates people, and you have to think about that for yourselves, like I said, because inevitably it's going to happen. You're going to get that challenge, and no matter where you end up, always try to concentrate on why you're doing what you're doing. It consistently refocuses me. And because I do so many things in my practice, I'll frequently have even other physicians locally, they'd be like, well, what don't you do? And I was like, I'm challenged to learn and do as much as I can do. But as an interventional radiologist, I have all the modalities of radiology open to guide how I treat and how I care for people. So it's not what I can do with my basis of radiology, it's why I do what I do. And in pursuing that quality of life, I'm in a non-traditional place where I'm an interventional radiologist practicing on my own, and it truly is because I embrace the care of people. Sounds kind of corny, sounds kind of cliche, but I embrace the care of people, and I embraced, I'll sit down, I talk to my patients, and I can guarantee you now the majority of my patients that come see me have come to see me because of other patients. You know, I have some entire golf foursomes. You get one good outcome on people, then he's like, yo, so-and-so's walking the whole course now. I mean, what'd you do to him? Can you do the same thing for me? So when you get that crap sandwich, remember, my previous slide was talking about resource utilization, but in the whole game of the practice of medicine, we are probably one of the most significant resources that we have to utilize appropriately, and we so rarely do it for ourselves. So remember why you're doing what you're doing. And this, even though corny, I had to put this in here because it really kind of strikes at home for me. Especially in this climate now. No man is an island entire of itself. Every man is a piece of the continent, a piece of the main. We are all a piece of that same body trying to perfect that dream that was democracy. And when he says, any man's death diminishes me because I'm involved in mankind, you have to embrace that in your practice. You have to embrace that in who you are and how you take care of these people, and you will always do the right thing for people. Okay, the pump technologies that exist are divided into two basic groups: a peristaltic pump, which is essentially a constantly moving rotor that moves medication forward. And because that motor is constantly moving, when that pump is first produced, it's filled with fluid, but that peristaltic pump, from the moment it's turned on, is rolling because that fluid within the pump is part of the lubrication. Swing ahead and look lower, the valve-gated microbolus pump, instead of delivering medicine in that kind of peristaltic, kind of rolling motor method, this pump is internally pressurized, it's valve-gated, so based on the duration of opening of those valves and how they fill, that then launches medication forward within the intrathecal space. We'll talk a little bit more about propagation of medicine in the intrathecal space and how it's been tied to effectiveness within the intrathecal space. But that's the two major differences. Is the method of delivery and the fact that one pump is internally pressurized in comparison to the other. The other thing I want to point out too that's also nice about the internal pressure, it means that emptying that pump and accessing that pump is a little bit easier for me. If I have a pump, one of the things, there are not a lot of things that can go bad, but one of the things that can go bad with filling a pump is that you can fill the pocket that the pump resides in. That's called a pocket fill. I will also just scan the pocket with ultrasound afterwards to just make sure that I haven't had a pocket fill. But also when you access this pressurized pump and you're filling it and you release, you will get some of that medication back. So you will get some positive feedback saying, yes, I truly am where I need to be and I'm delivering that medication where it needs to go. And so this is what it looks like in real time. You have a continuous flow rate of about 0.004 mLs per hour as compared to the 2 microliter boluses that happened about 50 times per day. So that microbolus being moved forward under pressure leads to greater dissemination within the intrathecal space, greater rostral spread, and that becomes significant. Okay, I missed a slide here. But so now you for whatever reason you selected a patient, be it typically in cancer patients, I got to the point where if they were willing, I just implanted them. In my last hospital, the majority of my cancer patients were referred to me, but what? It's like my woman, always listening to everything I do, man. I'm sorry, did I say that out loud? I'm sorry. But yeah, so you've arrived at that patient. At my previous hospital, the majority of my cancer referrals came from the pharmacist, who would call me up and say, hey, can you go see this patient? They're eating up all of our fentanyl. Because inevitably what happened is people came in, they either got put on a fentanyl drip, and it got turned up to you induce respiratory suppression. You go back a day later and they're going, and then they expire. And it was so frustrating to me because a lot of these people you could still see had viability, but for whatever reason, they weren't getting what I thought was the appropriate care. But then, like I said, once the pharmacist kicked in and she would say, hey, they're eating up all of our meds. Can you go see this person? So she actually became my number one referrer. But you reached a point, say, whether it's like the lady that I tell you had interstitial cystitis, highly functional, but she's tearful the entire time. She's had basically everything you can think of, multiple bladder surgeries, scrapings. She had just come back from a bladder Botox, and she said that set her pelvis on fire. She was literally screaming. So one of the things I see with hollow viscous, and also I see with pain related to post-laminectomy syndrome is outside of the pain, most people have significant muscular spasms. And so I've kind of just gone to the point now, and this is off-label, okay? This is off-label. I will have some baclofen added. And so I did this young lady's trial, which was, and keep in mind, these people are not opiate naive. So 1,000 micrograms of fentanyl, 50 micrograms of baclofen. They're with me for 2 hours. And literally you had to see it. She made everybody in the office cry. This lady just came off the table, huge smile, and she just started hugging everybody in the office. But her husband came back with her. And same thing, he's hugging everybody in the office. And I know, people ask me, well, why are you going to medicine? There's a component of me that needs to be loved. I just openly admit that. So you get a good home run like that and people are just loving on you and bringing you baked goods. A part of me just needs that. I'm telling you, I'm not gonna even be shy about it. I need to be loved. And so when you do something like that and you so significantly impact people's lives, it's absolutely amazing. But it gives me just those kind of warm fuzzies that I need, okay? So now you decide the patient's done well, you're gonna go to placement. Kind of basic steps. For people in radiology, people in IR who've done ports, I always tell people that this is a giant glorified port. Instead of putting my catheter into the superior vena cava, I'm putting it into the intrathecal space. Other than that, the pocket creation, as you kind of see there, it's pretty much similar to placing a port. So typically I have people in the decubitus position, I'll access them, and sometimes based on anatomy, that's the most difficult point. So I won't open up the pump traditionally until I have intrathecal access, have return to clear cerebral spinal fluid. I've already done my small cut down now, but I'll extend to posterior fascia, secure and anchor my catheter. I tunnel that over. It's kind of good to learn to create and find your pocket and mark your pocket prior to moving the patient into the OR, because based on the patient, there's going to be some skin movement, and what you thought was what moves, okay? So have that marked. Again, like I said, you tunnel over, you make sure you create the pocket, you place your pump, and after your pump's placed, you can kind of see this is a depiction of the fill Once you have the pump in his pocket, you close it however your method of closure. Then in the future, when they come back for refill, there's typically a template that will identify the pump. And one of the things I put in my op note is the orientation of my pump that I secure, so I always know how to apply my template. But typically, I ultrasound everything just so I can document pre and post. And now I'm at the point where my RN is typically doing all my fills now. So just, we talk about the idea of registry, and I really like that idea, because when you look at a lot of trials, they're taking what in many cases is an atypical or it's not a realistic patient that you see in everyday practice. So a colleague, Daniel Klosser, took several pancreatic patients and he started following his data on their survival. So he looked at people, like I said, stage 4, they're saying the median survival is 2.5 months. A lot of these patients, after they've come to you, they've had celiac plexus block or multiple type blocks, and they continue to do poorly, so they get implanted. He looked at 18 patients. These are their demographics. And what he demonstrated was a median survival in those 18 patients of 12 and a half months. 12 and a half months in comparison to 2.5 months. So what he clearly demonstrated kind of follows what we saw in those randomized controlled trials, that there was a definite survival benefit. And this was in all takers, all comers, patients with stage 4 pancreatic cancer. So again, I'm a single practitioner, and so I told you a story. I got to the point where I was in those 2 rooms that my buddy had cleared out for me. I had this little old ultrasound machine, and he gave me my first 2 patients, and that kept growing, But in those early stages, one of the things that continued to drive me was, I was seeing every patient that got referred for almost anything, and then I was trying to keep that office open and keep it afloat. But intrathecal targeted drug delivery is the appropriate thing to do for many patients, but more than that, it's a way to establish a relationship with a patient. And when you take good care of those people, they continue to come back. And so, like I showed you that gentleman who had the vascular and then the venous issues, he was treated with bilateral lower extremity angio, then venogram, then pelvic stenting, and now he's a guy that comes to me every 6 weeks for evaluation and maintenance of his intrathecal pump. But when he comes back and he's in his chair and he has wrist pain or shoulder pain, I'm now doing MSK ultrasound of that shoulder, or someone's doing it for me. I'm doing blocks of that shoulder. I'm doing cool leaf for that shoulder. And these people, once you've taken care of them, they don't want to see other people. So just an ability to affect a lot of lives, and in a way I know I'm delivering quality care, because another thing that happens is people will come to me for a referral and they'll say, well, I had this or that done, and my response is, that doesn't mean it was done well. At least when I do something and I have you, I'm assured that it was done within appropriate level of quality. And if you're unresponsive, then we can kind of progress to other therapies, which frequently does include intrathecal targeted drug delivery. Just leave you with this, and whatever your politics are now, and a lot of times people say, we don't want to talk politics. I want to talk politics because I want to challenge us to be better, not just better physicians, but better people. But if William Seward, after reading President Lincoln's first inaugural address, he gave him these suggestions. But listen to this prose. Look at that prose. Although passion has strained our bonds of affection too hardly, they must not. Contrast that to that's bullshit, or the stuff that we're hearing now. But one of my favorite lines in any literature is this final couple of sentences. Lincoln put forward in his 1861 inauguration, the mystic chords of memory stretching from every battlefield and patriot grave to every living heart and hearthstone all over this broad land will yet swell the chorus of the Union when again touched, as surely they will be by the better angels of our nature. I mean, that's what I seek you. That's what I challenge you to do every day. Find the better angel of your nature, apply that to people's lives, and you will make a difference. Your world may be small, but if you apply that seeking of better angels to people's nature, you're gonna do the right things for them. You're gonna do things like learn kyphoplasty, which you've heard here, that so significantly impact people's lives. And you're gonna do everything you can to become a better person for those people you're taking care of. But remember, chief amongst those is ourselves.